All right, party people, we are back at it with more microbiology. Let's get it. All right, jumping into Bacillus cereus. This organism is classically known for causing diarrhea or vomiting after the eating of fried rice or reheated rice. So the sickness results from spores that germinate at high temperatures. Bacillus cereus can also cause eye infection. This is classically post-surgery. For USMLE, the exam isn't just going to mention the eye infection and expect you to guess B. cereus. Instead, they might give you a patient who had an eye surgery and now has an infection caused by gram-positive rods. And if the answer choices include, for example, a gram-positive cocci in clusters, Staph aureus, or a gram-negative rod, E. coli. But if the only gram-positive rod is B. cereus, that's your answer, even if you only originally knew that it was associated with food poisoning. Next up, we have Bacillus anthracis, no Osama. All right, let's get it. So this is the classic cause of anthrax, which can be cutaneous or pulmonary. The cutaneous anthrax causes a black, painless ulcer with surrounding edema. The key toxin here is edema factor. This factor increases CAMP. Now, other organisms and toxins that also increase CAMP include ETEC, heat labile toxin. This causes traveler's diarrhea. Vibrio cholera. This is cholera toxin and it causes high volume rice water diarrhea. Bordetella pertussis increases CAMP and inactivates G inhibitory protein. This also raises CAMP. So a unique fact about B. anthracis, it is the only bacterium with a protein capsule. This is the poly-D-glutamic acid. Unlike other encapsulated organisms that have polysaccharide capsules, such as strep pneumo, Neisseria meningitidis, H. influenza type B, etc., Bacillus anthracis spores contain diplocholinic acid, making them heat and acid resistant, allowing survival in harsh conditions such as contaminated animal hides. This explains the so-called wool sorter's disease with the presentation of pulmonary anthrax. Clostridium tetani. So tetanus toxin inhibits presynaptic snare proteins, decreasing the release of inhibitory neurotransmitters, glycine and GABA, in the CNS. The result is spastic paralysis and increased muscle tone. So classically what you'll see on USMLE is a neonate born at home with the umbilical cord cut with a kitchen knife and then tied with twine. Later, the baby presents with an arching of the back. This is the opisthotonos due to the tetanus. The toxin enters through the umbilical stump. Now let's just do a quick review of the vaccine schedule for tetanus. All right, so the primary series is at 2, 4, 6, and 12 months of age. Boosters at 4 and then starting at age 10 or 12. For post-exposure prophylaxis for tetanus, if the patient's been vaccinated within the past 5 years, no vaccine or IVIG needed. If vaccinated 5 to 10 years ago and it's a clean wound, no treatment required. If the wound is dirty, you give a vaccine only, no IVIG. If the patient was vaccinated over 10 years ago with a clean wound, you give only the vaccine. If it's a dirty wound, you give both vaccine and IVIG. Now, just as a fun fact, when you see trismus, it's lockjaw, seen in tetanus. Tenesmus is the constant urge to defecate. This is seen in dysentery or irritable bowel disease. Don't mess these up. Now moving on to Clostridium botulinum. Botulinum toxin also inhibits snare proteins, but instead of blocking inhibitory neurotransmitters, it blocks the acetylcholine release at the neuromuscular junction. This results in flaccid paralysis. Textbook presentation is an infant who ate spores in the honey, which resulted in floppy baby syndrome, or older children/adults who ingested preformed toxin from an improperly canned food. This is often associated with camping trips. So symptoms would include, for neonates, the floppy head as well as poor muscle tone. In the older patients, look for cranial nerve deficits like dysphagia, dysarthria, Bell's palsy, descending paralysis with the eventual respiratory compromise. All right, that's it for this one. Go crush it.